Hello everyone, we are going to cover the series of biomechanics in which first comes the hip joint. So it is also known as coxofemoral joint or a femoroacetabular joint. It has the articulation of acetabulum of pelvis and femoral head. In the next slide you will see the diagram. The type is ball and socket variety which allows the 3 degree of motion, that is flexion, extension, abduction, adduction, medial and lateral rotation. Next is the function. Hip joint concerned with the supporting weight of head, arm and trunk in both static and dynamic activity. Here you can see the diagram where the head of the femur is articulated with the acetabulum of the pelvis. Proximal articulating surface is acetabulum, which is a deep cavity, and it is directed laterally, anteriorly and inferiorly. Distal articulating surface is femoral head, which is more circular than the acetabulum, and it is directed superiorly, medially and anteriorly, and it is covered with the hyaline cartilage. Hip joint is most congruent, but head of the femur is little larger than the acetabulum. So during non-weight bearing condition, the femur become exposed, and it can be fixed by coming in a frog-like position, but during weight bearing condition, elastic deformity forces acting on the acetabulum increases. Next, there are four angulations, in which first comes the center edge angle, which is also known as angle of Wisberg. This is the angle formed with the line joining the lateral rim of acetabulum and center of the head of the femur. Second is acetabular anteversion. It is angle defined as the total magnitude of anterior rotation, in which increase in the angle tends to decrease in stability and increase in chances of anterior dislocation. The third is angle of inclination. This is the angle formed by the axis passing through the head and the neck of the femur and the longitudinal axis of the femoral shaft. The increase in angle is termed as a coxa valga and decrease in angle termed as a coxa vara. Here you can see the diagram, which is normal, it is 125 degree, coxa vara, which is decrease in angle, it is 105 degrees, and coxa valga, which is increase in angle, is 140 degree. And last is the angle of torsion. This is the angle formed between the axis passing through the head and the neck of the femur and axis passing through the condyle of the femur. Increase in angle called as femoral anteversion and decrease in angle called as femoral retroversion. Here are the diagrams of the anteversion and retroversion. For anteversion it is 45 degree and retroversion 0 degree. Then comes the attachments. So first is joint capsule, which is the articular capsule of the joint is irregular and dense fibrous structure with the longitudinal and oblique fibers. Then there are four ligaments: iliofemoral, ischiofemoral, pubofemoral and ligamentum teres. Iliofemoral ligament, it is the strongest and thickest ligament. It is placed anteriorly. Ischiofemoral ligament comes posteriorly, which attaches the posterior surface of the acetabular rim. Third is pubofemoral ligament. It is also comes anteriorly and is a sling that support the femoral neck. Ligamentum teres, it is a triangular band and does not support to stabilization. And here are the diagrams of the ligaments. Then most important is kinetics and kinematics. So first of all, write about the definitions of that. Kinematics is a branch of biomechanics that deals with the motion without taking into the force producing it. In this comes osteokinematics and arthrokinematics. So first is osteokinematics. It deals with the rotatory movement during the joint motion. Remember this chart according to the movement, plane, axis and range of motions. Next is arthrokinematics. Don't get confused about the arthro and osteo. In arthrokinematics, there are rolling and gliding movement which occurs. We have covered the kinematics, in which we have seen arthrokinematics and osteokinematics. Now the kinetics, in which muscles are important. For flexion, there are primary and secondary muscles. In primary, psoas major and iliacus, and in secondary, TFL, rectus femoris and sartorius. During extension, primary muscles are gluteus maximus and secondary is hamstring, adduction, adductor magnus and adductor longus, adductor brevis, pectineus, gracialis and obturator externus. During abduction, gluteus medius and minimus and secondary muscle is TFL. During medial rotation, TFL, gluteus minimus and the anterior fibers of gluteus medius. And during lateral rotation, primary muscles are piriformis and gluteus maximus. You can also draw this diagram in your exam. There are some clinical terms which can be asked in your exam for 7 marks and in your viva also. So anterior and posterior pelvic tilt, which produce the flexion and extension simultaneously. During anterior tilting, the pelvis brings ASIS anteriorly and inferiorly, and inferior sacrum moves farther from the femur, and vice versa happens during the posterior tilt. Here in diagram you can see the anterior and posterior tilting of the hip joint. Next we have a lateral pelvic tilting which occurs in unilateral stance. It means when one leg is stable on the ground, it can either elevate the pelvic hike or drop. Next is pelvofemoral motion. It can be asked separately in exam. It means when the pelvis, femur and spine moves in a coordinate manner and produce larger range of motion. It increases the range of motion, and it also referred as a pelvofemoral rhythm, which implies to continue relation between the two segments. Lastly, we have uses of cane. This question has been asked in practical exam. On ipsilateral side, by holding a cane in a hand of the side of the pain can reduce the weakness or the superimposed body weight. And on contralateral side, when the cane is moved, the side opposite to the painful or weak joint, the reduction in magnitude is the same as it when the cane is used in ipsilateral side. Benefit is that the downward force can be acted through the full distance between the hand and weight bearing hip joint. Thus, holding the cane in contralateral side is more beneficial than holding it on a ipsilateral side. In this video, we have covered the hip joint biomechanics, which is most important question. So, if you understand it, please write it down and draw the diagrams.